Welcome back to Free Speech Nation with me, Andrew Doyle. This is our special on the WPATH Files. Now, in preparation for this show, we have been attempting to secure interviews with medical professionals who support gender-affirming care. We approached 33 different members of WPATH and invited them all to appear. All 33 either declined or did not get back to us at all. However, I am delighted to say that Barrister Moira White, who does support gender-affirmative care, has agreed to talk to me, and Robin joins me now. Robin, I do really appreciate you being here because it has been very difficult to get people to support gender-affirming care. I think it's very important that all sides of this debate are heard. And I know you can't speculate about what's going on in other people's minds, but why do you think it might be that so many medical professionals won't talk to me?
Well, your previous guest, Helen Joyce, described trans people as a terrible problem in a sane world. I think I've probably got that quote a word or two wrong. And I think there is a feeling that I've seen your guest list for this evening. I am the only person who's going to be speaking in this direction.
That's right, that's right. And Robin, but in terms of the invitations, there were more people invited from your side of the debate than from the other. It just so happens that you have accepted it. I will, by the way, put that to Helen when I see her again later on.
And to be fair, I wavered in coming on because I'd seen the way this evening was advertised, and I am concerned that the debate about trans people is toxic and difficult for trans people to engage in.
Well, let's talk about it then from your perspective. Let's hear your view. You yourself have experienced gender-affirmative care. And so you've had a very good experience. Could you tell us about that?
Yeah, I struggled with my gender since I was very young. I perhaps would have transitioned in my 20s, but I suffered horrible workplace discrimination that ended a career that I loved, and I had to go and find another one, which was law, and got to my early 40s and decided that either I had to transition or, frankly, jump off a cliff, and went through WPATH moderated treatment, so with appropriate psychological investigations, appropriate counselling, before there was any hint of prescription or any hint of surgery later. And I've been right through everything I've had done. I've been properly informed about, I've consented to properly. And there's an example in the other direction. I'm an oral advocate. One of the types of surgery that's possible is surgery to vocal cords. And I went through, I thought seriously about that, but because I'm an oral advocate, it risks me ending up sounding like Minnie Mouse and a bit ridiculous. And obviously, if I was like that in court for a day, you wouldn't be listening to what I was saying, you'd be listening to that. And I took an informed choice not to have that surgery.
And you have some reservations, don't you, about the content of the WPATH files?
Well, firstly, the video are people having a discussion. They're not, as I understand it, it's in no sense an official position from WPATH.
Yes, that's a point I made earlier, yes, yes.
And I have some significant problems with the report that's been written. There's an American trans journalist called Erin Reed who's looked at the report and has hundreds of criticisms of the report. And I suspect you ought to make some attempt to have her here to discuss that.
Erin was invited to appear today.
Well, indeed. So let's take, and I gave you one example in advance of speaking. So the report talks about the level of detransitioners, and I know you're going to be talking to a detransitioner later. The studies show that detransitioning is down at single percents. That's what the studies of detransitioners show. That's very low in terms of regret rates for surgery. A comparison would be hip or knee surgery often has regret rates of between 20 and 30% because people end up with... And what the report says, the report looks at a study, and the people who wrote the study themselves question, they go, oh, this low single percent looks very low. The report quotes that, but what it doesn't do is quote 4 lines later when the investigators have looked at the reasons why that is low and say, there's no reason to doubt the figures.
But isn't it the case that we don't really have the data on detransitioners insofar as that a lot of them are those who are no longer on the doctor's books, and a lot of this data is drawn from the people who are still patients of those doctors?
No, there are some very recent, very well worked through studies, and every study comes out with very low numbers.
Can I ask you, with your support of gender-affirming care, I've looked through the WPATH standards of care, and it's very clear that a lot of it is driven by a notion of gender identity. Can you explain to me what is gender identity?
Well, I guess I'm old in that sense, and we've moved to gender incongruence is the phrase that people prefer these days.
Yes.
In a sense, in my view, when I was being treated, the standard was gender dysphoria. And dysphoria is a word that basically means discomfort.
Yes.
And from the age of 7 or 8, I was immensely uncomfortable with having to present to the world as male.
So it's a feeling, though, based on, you say, presenting to the world as male. Is it based on stereotypes of gender, dressing a certain way, acting a certain way, being tough or rough and tumble, or being femme? What is it?
No, not at all. There's an essence of male or female.
An essence.
If you meet me in the West Country, you'll most likely find me in jeans gardening.
So it's not about the way you look?
No, it's not about a particular thing, but there is maleness and femaleness.
I mean, I'm serious about this, Robin, because it's something I really want to understand. I looked at the WPATH definition of gender identity in the glossary. It says it refers to a person's deeply felt, internal, intrinsic sense of their own gender. That sounds very much like a circular definition to me, and I can't work out what they mean by that. It's
a bit like colour to a blind man, because if and you, fortunately, are one of those people whose sense of yourself matches the gender or the sex in which you were born. And I
don't have a gender identity. I am just male.
Well, for you, those things match. For me, they didn't match. And for trans people, they don't match.
So, but are you not concerned, Robin, about... I mean, you had a very good experience, and I completely respect that and accept that. But there are an awful lot of people who haven't had a very good experience, and there's a lot of whistleblowers coming out saying, you know, from the Tavistock and places like that, people who are working within the system saying it has to change. So shouldn't we at least be having a conversation about whether gender-affirming care is the right way to go?
Absolutely, a conversation is fine, but we have to... I'm a scientist who became a lawyer, so I love evidence, all right? Evidence is the right way forward. And back to the studies we were talking about, and they consistently come out with very, very low levels of regret. And you're absolutely right. We should continue to follow people through the process. We should see how that works. And for those people who end up in a position of regret, that's awful for them. But what you don't do in the hip replacement example is, because 20% of people come out of a hip replacement with a bad experience, you don't say the other 80% shouldn't have the hip replacement.
OK, well, Robin, I would love to be able to talk to you about this much more. We are running out of time. Just very finally, this idea of evidence-based, I think we all agree that scientific procedures should be evidence-based. But if that is based on what you describe as an essence of maleness or an essence of femaleness, it sounds like a soul. It sounds something metaphysical to me. How is that compatible with a medical procedure?
Well, almost all psychological positions depend on interviewing somebody, finding out how they feel about themselves, how they interact with the world around them. We don't yet have some form of laser that can look into your brain and say, you know, is this how it is? We have to listen to people and understand how they are and who they say they are.
Robin Moira White, thank you so much for joining me. Really appreciate it.